Welcome back to the deep dive. Today we're doing something a little bit different. If you've been with us for previous deep dives, we usually pick a single topic and drill down. Maybe it's a specific pathogen, a specific drug mechanism, or, a landmark study.
Right. We usually go micro. We get into the weeds of the cell wall or the genetics.
Exactly. We do the roll call. We memorize the Latin names. We look at the Petri dish. But today we're zooming out. We are shifting gears from the classroom to the clinic. We're moving away from what medical students often dread as the bug parade.
Oh, the bug parade?
Yeah, just memorizing list after list of organisms.
Yeah.
And we are switching into what we can call detective mode.
Which is a transition that sounds easy on paper, but honestly, it trips up almost everyone when they first start practicing medicine. It's the organism to organ pivot.
Because patients don't read the textbooks.
They really don't. A patient never walks into the ER and says, "Excuse me, doctor, I believe I have a gram-positive Diplococcus infection in my left lower lobe."
That would make the job infinitely easier.
It would be boring. Instead, they walk in and say, "I can't breathe," or "My head feels like it's going to explode," or "I stepped on a rusty nail and now my foot is throbbing."
So today, we're synthesizing. We're taking the massive catalog of bugs from Murray's Medical Microbiology, specifically Chapter 78, which is our structural spine and roadmap today, and we're layering in the clinical reality from Gerwetz, Melnick, and Edelberg.
Right, because we are answering the fundamental question, what causes infection here, rather than what does this bug do?
That's the mission. We're going to organize pathogens by body system. This matches the way a clinician actually thinks.
Yeah.
You start with the anatomy of the syndrome, and then you work backward to the bug.
I like to think of it like the difference between memorizing the roster of a sports team, knowing everyone's stats and height and weight, versus actually watching the game and seeing how those players interact on the field.
That is a perfect analogy.
Yeah.
Because in the body, it is a dynamic game.
Yeah.
Decisions interact. The defense your immune system adjusts.
Exactly. And to make this really practical, we need to talk about the filter we use before we even order a single test. Because it's not just about where the infection is it? It's about who the patient is.
The who. This is the concept of host factors.
Absolutely. In microbiology, context is everything. If I tell you a patient has meningitis, you can't tell me the likely bug until I tell you their age.
It's that black and white.
It really is. A newborn baby has a completely different biological ecosystem than a 20-year-old college student, who is different from an 80-year-old on chemotherapy. Geography matters too.
Like where they've traveled.
Yeah. Have they been spelunking in caves in the Midwest? Have they been swimming in freshwater lakes in the summer? These factors narrow the differential diagnosis from 1,000 possibilities to maybe 3 just by looking at the patient.
So we're playing detective. We're building a profile before we even swab anything or draw blood.
Exactly. That is the true art of the differential diagnosis.
All right, let's start at the top. The highest stakes environment in the body. The central nervous system.
The CNS. The brain and the spine. This is where the clock is ticking the loudest.
Specifically, meningitis. It's the word that scares every parent, every college kid, every doctor, and for good reason.
It is a medical emergency. You cannot wait. The brain is inside a closed box, the skull. If you get infection and inflammation, there is literally nowhere for the swelling to go.
It just builds pressure.
It compresses the brainstem, it herniates, it kills you.
So clinically, what are we looking for? What's the red flag that tells us, okay, we need to move fast?
We look for the classic triad: fever, headache, and neutral rigidity.
Neutral rigidity. That's just a fancy way of saying a stiff neck, right?
It is, but it's specific. It's resistance to passive flexion. If I try to bend your chin to your chest, it hurts and the muscles lock up. It's a protective reflex because the meninges, the lining of the spine, are inflamed.
Are there other signs?
Yeah, you also have to look for photophobia, sensitivity to light, and altered mental status. If grandma is confused and has a fever, you have to rule this out.
And to rule it out, we need the liquid gold.
Cerebrospinal fluid. CSF. You have to do a lumbar puncture. You have to tap the spine.
I want to spend a minute here because this is where the real insight comes in. You get this fluid back from the lab. It's just numbers on a page. Glucose, protein, cell count. How do you read the tea leaves? How do you know if it's a bacteria, a virus, or a fungus just by looking at those 3 numbers?
It comes down to understanding the personality of the organism. Let's start with bacteria. Bacteria are living, dividing, metabolic machines. They are hungry. Their primary fuel source is glucose.
So they eat the sugar in the spinal fluid.
They devour it. If you have bacterial meningitis, the glucose in your CSF will be rock bottom. We call it hypoglycemia. Normal CSF glucose is usually about 2/3 of your blood sugar. In bacterial meningitis, it might be 0.
Okay, so low sugar equals bacteria. What else?
Bacteria are messy. They provoke a violent war. The body sends in the Marines, the neutrophils, or PMNs. So your cell count goes from near 0 to thousands, and it's almost all neutrophils. And because of the war, the dead bacteria, the immune cells, the leakage from blood vessels, the protein levels shoot up.
So let me anchor this. Low sugar, high neutrophils, high protein. That's the bacterial profile. Because bacteria are hungry and messy.
Precisely. Now, contrast that with virus. Viruses aren't alive in the same metabolic sense. They aren't eating lunch. So in viral meningitis, the glucose is usually normal.
That's the tiebreaker.
It is the most helpful differentiator. If the glucose is normal, it's probably viral. The cell count will be elevated, but it's different soldiers, it's lymphocytes, not neutrophils, and the protein is usually only moderately elevated.
And then you have the tricky ones, the chronic meningitis. Fungal or tuberculosis.
These are the slow burns. They present like a mix. You get the lymphocytes of a virus, but the glucose is low, like a bacterium, though usually not as dramatically low as in acute bacterial cases. And the protein is high. It reflects a simmering long-term inflammation.
Okay, so let's say the glucose is floored. We know it's bacterial. Now we have to figure out which bacteria so we can choose the right antibiotic. This brings us back to that age-based mental model you mentioned earlier.
Right. It is the single most important filter for empiric treatment. Let's walk through the timeline of life. Start with a neonate, a baby less than 1 month old. Where did they get their bugs?
From the mother.
Specifically, the birth canal. It's a traumatic exit. They are exposed to whatever is colonizing the mom. So the big three, the birth canal bugs, are Streptococcus agalactia, also known as group B strep, Escherichia coli, and Listeria monocytogenes.
So if a 2-week-old has meningitis, you aren't worrying about coughing strangers. You're worrying about vaginal flora and gut flora.
Exactly. That is what they are exposed to. Now, fast forward. The child grows up, goes to school, maybe heads off to college. They are in dorms, military barracks, close quarters. The landscape changes.
A dorm room danger.
Neisseria meningitis, the meningococcus. This is the one that causes outbreaks. It lives in the nasopharynx and spreads by droplets. Streptococcus pneumonia is always there too, of course. But Neisseria is the specific threat in young adults.
And Neisseria has a specific sign, right? Something scary on the skin.
The petechial or purpuric rash. If you see a student with a stiff neck and these little non-blanching red or purple spots on the skin, meaning they don't fade when you press a glass tumbler against them, that is Neisseria meningitis until proven otherwise.
Wow.
It's a sign of sepsis and blood vessel destruction. It kills in hours.
The tumbler test, the classic. Now let's move to the elderly, over 50.
As we age, our immune system changes. Specifically, our cell-mediated immunity, the part that fights intracellular bugs, starts to fade. So Streptococcus pneumonia is still the heavyweight champion, the #1 cause. But suddenly, Listeria monocytogenes comes back into the picture.
Listeria returns. It's like a bookend. You see it at the start of life and the end of life.
Exactly. And this is critical for treatment. Standard meningitis antibiotics like ceftriaxone or vancomycin do not kill Listeria.
Really?
They are totally ineffective against it. So if you have a 60-year-old patient or an immunocompromised patient, you must add ampicillin to your drug regimen. If you forget the ampicillin and it's Listeria, the patient dies.
That is a massive clinical pearl. Age dictates the drug cocktail.
It has to. You don't have time to wait for the culture to grow. You have to guess right the first time.
Let's shift gears slightly within the CNS. Meningitis is an infection of the fluid and lining. But what about when the infection forms a mass? A brain abscess.
A space-occupying lesion. This presents differently. It acts like a tumor. You get headache, maybe focal neurological deficits like weakness in one arm, depending on where the abscess is sitting.
How do bacteria even get into the brain parenchyma to form an abscess? Seems pretty well protected.
It is, but it has neighbors. The most common way is direct extension. Think about the real estate. The brain is sitting right next to the sinuses, the ears, the teeth.
So a bad tooth infection can become a brain abscess.
Absolutely. Or a chronic middle ear infection or sinusitis. The bacteria can erode through the thin bone and invade the temporal or frontal lobe. Because of that source, these abscesses are usually polymicrobial. It's a mix of mouth floroviridins, streptococci, anaerobes like spufageroids, and fusobacterium. It's a zoo in there.
And the second way is through the blood.
Hematogenous spread. This often comes from infective endocarditis infection of the heart valves throwing septic emboli up into the brain. If you see multiple abscesses on a scan, you assume it came from the blood.
And I remember seeing MRI scans where you have to differentiate an abscess from a tumor. They can look similar.
They can. They both can show ring enhancement on contrast scans, that bright ring around a dark center. And in HIV patients, you have another player. Toxoplasmosis, that's a parasitic infection that loves to form ring-enhancing lesions in the brain when the CD4 count drops. So the differential there is crucial. You have to look at the whole patient. Does he have a bad tooth? Think abscess. Does he have untreated HIV? Think toxoplasma.
Okay, let's move down. We're leaving the brain and heading to the chest, the respiratory system, from sniffles to full-blown consolidation.
The respiratory tract is basically a long tube, but we divide it into upper and lower because the pathogens and the stakes are quite different.
Starting with the upper respiratory tract. Pharyngitis, sore throat.
Most of the time, pharyngitis is viral. It's miserable but self-limiting. However, the can't-miss diagnosis here is Streptococcus pyogenes or group A strep.
Strep throat. We've all had it.
Yes. But here is where it gets really interesting. We don't treat strep throat primarily to make the throat feel better. I mean, antibiotics help a little with symptoms, but that's a nice bonus. The real reason we treat it with antibiotics is to prevent the sequelae, the complications that come after the infection.
You're talking about rheumatic fever.
Rheumatic fever and glomerulonephritis, which is kidney damage. Group A strep has a protein on its surface called the M protein that looks very similar to proteins in our heart valves and joints.
Molecular mimicry.
Exactly. If you let the infection run rampant, the immune system makes antibodies against the strep that end up attacking your own heart valves weeks later. That's rheumatic heart disease. That's why we treat.
That's a great reminder. It's preventative medicine disguised as acute treatment. What about epiglottitis? I feel like we hear about this less now, but it's still a medical emergency.
It is the definition of an airway emergency. The epiglottis swells up and can block the windpipe completely. Historically, the main culprit was Haemophilus influenza type B, or HIB.
But we have a vaccine for that now.
We do, and it's been a miracle. The incidence has plummeted. But you still see it in unvaccinated kids or rare cases. On X-ray, you look for the thumbprint sign. The swollen epiglottis looking like a thumb sticking into the airway.
Let's go deeper. Into the lungs. Pneumonia. This is a massive topic, so we need to break it down. Community-acquired versus hospital-associated.
That distinction is vital because the bugs are completely different. Let's start with community-acquired pneumonia, or CAP. You are walking around in the world and you get sick. The undisputed champion here is, again, Streptococcus pneumonia.
The pneumococcus.
The pneumococcus. It causes a classic lobar pneumonia, meaning it wipes out a whole lobe of the lung. And the textbook detail that always comes up is rust-colored sputum.
Which is essentially old blood coming from the alveoli.
Exactly. It indicates alveolar bleeding. But then you have the atypicals. We call them atypical because they don't look like standard bacteria on a gram stain. They don't have a cell wall like mycoplasma, and they present a bit differently.
Walking pneumonia.
Right, mycoplasma pneumonia. Usually young adults, college students, they feel terrible, bad cough, but they aren't bedridden, hence walking. And then there's Legionella.
The air conditioner bug.
Yes, associated with water sources, cooling towers. Legionella has a unique signature. It often causes hyponatremia, low sodium, and confusion. If you see a pneumonia patient who is confused and has low sodium, think Legionella.
And viral causes are huge, too. Influenza, RSV in kids, adenovirus. But let's talk about the bad stuff. You go to the hospital for a knee replacement, and 3 days later you have pneumonia. Hospital-associated pneumonia, or HAP.
This is a different beast. We have a saying. The flora changes within 48 hours of hospitalization. Your nice, normal mouth bacteria get replaced by angry hospital bugs.
The villains.
The villains. Pseudomonas aeruginosa, the water-loving bug. It's resistant to almost everything. It's a major issue in cystic fibrosis patients, too. Then there is Klebsiella pneumonia,
which has the most descriptive sputum of all time. Currant jelly.
It's gelatinous, bloody, thick. Klebsiella is classic in alcoholics and people prone to aspiration. And, of course, MRSA, methicillin-resistant Staphylococcus aureus. This often comes in as a superinfection after a viral illness like the flu. You get the flu, you start to recover, and then boom, MRSA pneumonia hits you.
Now, before we leave the lungs, we have to talk about spit, because getting a good sample is apparently harder than it sounds.
It is the bane of the microbiology lab. You ask a patient for sputum, and they just spit in a cup. That's saliva. Saliva is full of mouth bacteria, squamous epithelial cells. If you culture that, you just grow normal mouth flora. It's useless.
So what's the rule?
The lab looks at the sample under a microscope. To call it sputum, it needs to have greater than 25 neutrophils, meaning infection, and fewer than 10 epithelial cells per field.
Yeah.
If it has tons of epithelial cells, it's just spit. Reject it. Don't treat based on it.
Good rule. Don't culture spit. Okay, let's circulate to the cardiovascular system, the pump and the pipes. Infective endocarditis.
This is an infection of the heart valves themselves. The mechanism is usually a two-hit hypothesis. First, you need some endothelial damage on the valve turbulence, scarring. That creates a rough spot where platelets and fibrins stick. Then you need bacteremia, bacteria in the blood. The bacteria stick to that platelet clump and grow into a vegetation.
A vegetation. That sounds ominous.
It is. It's a clump of bacteria and clot protecting itself from the immune system.
So who are the culprits here?
It depends on the valve. If it's a native valve, your own natural valve. We look at viridans streptococci. These are mouth bacteria.
The dental work connection.
Exactly. You get a root canal, bacteria get into the blood, they find a damaged valve, and they set up shop. It's usually a subacute course, slow, low-grade fevers. But if it's Staphylococcus aureus on a native valve, that is acute, destructive, and toxic. It can eat through a healthy valve in days.
What about artificial valves, prosthetic valves?
There, we worry about Staphylococcus epidermidis. It's a skin bug, not usually very virulent, but it loves plastic. It forms a slime layer, a biofilm on the prosthetic material that makes it almost impossible to kill with antibiotics alone.
And we have to mention IV drug use.
Yes. IV drug use introduces skin flora directly into the veins. The first valve they hit is the tricuspid valve on the right side of the heart. So S. aureus tricuspid endocarditis is the classic presentation there.
The physical exam for endocarditis seems like something out of a 19th century medical textbook. It has all these names, Roth spots, Janeway lesions.
It is the hands and eyes exam. You really have to look. Roth spots are retinal hemorrhages. You see them looking in the eye. Janeway lesions are painless red spots on the palms and soles. Osler nodes are painful, raised bumps on the finger pads.
And the mnemonic there is easy. O for Osler, O for ouch.
Exactly. And splinter hemorrhages under the fingernails. These are all signs that the vegetation is throwing off little pieces emboli that are getting stuck in tiny capillaries.
And to diagnose this, you need blood cultures. But you can't just take one.
Never just one. You need 3 sets, drawn from different sites, over 24 hours. You need to prove continuous bacteremia. If you only get 1 positive culture out of 3, it might be a contaminant. If you get 3 out of 3, that's endocarditis. And the golden rule: don't rush antibiotics unless the patient is unstable. You want to capture the bug first.
Right. If you sterilize the blood before you culture, you'll never know what you're treating. Moving on to the gastrointestinal tract. The in versus out system.
This is a system where the history tells you almost everything. Specifically, the timeline.
The symptom timeline. Nausea versus diarrhea.
Right. If a patient gets sick within hours, say 2 to 6 hours after eating, that is too fast for a bacteria to grow and cause infection. That is a preformed toxin. The bacteria grew in the food, made a toxin, and you ate the toxin. It's basically a chemical poisoning.
Food poisoning in the strictest sense.
Yes. The classic culprit is Staph aureus. Imagine potato salad or cream pastries left out at a picnic. The staph grows, makes enterotoxin, you eat it, and boom, violent vomiting a few hours later.
And Bacillus cereus.
That's the fried rice syndrome. You reheat rice, the spores germinate, produce toxin, typical in buffet rice.
So that's the fast track. What about the medium track?
8 to 16 hours, Clostridium perfringens, often from rewarmed meats. That gives the bacteria just enough time to sporulate in your gut and release toxin.
And then the long incubation. Days.
That's true infection. The bacteria have to invade or adhere and replicate. That's when diarrhea becomes the dominant symptom. And here we divide it into 2 buckets. Watery versus bloody.
Watery diarrhea. Secretory.
Think Vibrio cholerae, rice water stool, massive fluid loss. The mechanism is a toxin that turns the cell's water taps on full blast. Then there is E-tech, enterotoxigenic E. coli, which is traveler's diarrhea.
And viruses.
Rotavirus in kids, though vaccines are helping.
Yeah.
And norovirus, the cruise ship bug. It hits close quarters hard, highly contagious.
And parasites.
Giardia, the camper or hiker bug from drinking stream water. It causes foul-smelling fatty stool because it blocks fat absorption.
Okay, now the scary bucket. Bloody diarrhea. Dysentery. This implies invasion tissue damage.
Correct. Shigella is the prototype. Low infectious dose, it doesn't take many bacteria to make you sick. Severe cramping. Salmonella from poultry or reptiles. Campylobacter, also poultry. It's actually the most common bacterial cause. And it has a dark association, Guillain-Barré syndrome. Sometimes the immune response to Campylobacter cross-reacts with your nerves and causes paralysis.
And then there's the one we see in the news, E. coli O157.H7, EH.
The undercooked beef bug. It produces Shiga toxin. And this is critical. If you suspect EHEC, you generally do not give antibiotics.
Why not?
Because killing the bacteria can cause a massive release of toxin, which precipitates HUS hemolytic uremic syndrome. It shreds the kidneys. So for bloody diarrhea, we are very cautious with antibiotics until we know what we are dealing with.
And one final GI villain, antibiotic-associated diarrhea.
Clostridium difficile, or C. diff, now officially called Clostridioides difficile. It's a spore former. You take antibiotics for something else, you wipe out your good gut flora, and C. diff takes over. It causes pseudomembranous colitis.
Section 5, the genitourinary tract, plumbing issues.
UTIs are incredibly common, and the usual suspect list is short. E. coli causes 80 to 90% of uncomplicated cystitis. It has these little hairs that allow it to climb up the urethra and stick to the bladder wall.
But there's a specific one for young women.
The honeymoon bug, Staphylococcus saprophyticus. It's a common cause in young sexually active women.
And when we look at the lab report, what defines a UTI?
Technically, greater than 10 to the fifth 100,000 colony-forming units per ml is the classic definition. But in a symptomatic patient, someone with dysuria and frequency lower counts still matter. You treat the patient, not just the number.
What if it's a complicated UTI, someone with a catheter or kidney stones?
Then the bug list expands. You see Proteus, which is associated with kidney stones because it makes the urine alkaline. You see Pseudomonas and Enterococcus, the resistant bugs.
Let's talk about the other side of GU, sexually transmitted infections, STIs.
We can group these by presentation, too. The discharge versus the
The discharge, urethritis or cervicitis.
The dynamic duo here is Neisseria gonorrhea and Chlamydia trachomatis. Gonorrhea is the drip, gram-negative intracellular diplococci. Chlamydia is the silent epidemic, often asymptomatic, but it can cause scarring and infertility. And they are friends. Co-infection is so common that we typically treat for both if we find one.
And the ulcer.
The genital sort. The key discriminator is pain. If the ulcer is painful, think herpes simplex, which forms vesicles, or Haemophilus ducreyi-chancroid. The mnemonic is you do cry with Ducrey.
And if it's painless.
That is the chancre of syphilis. Treponema pallidum, a hard, painless ulcer. It's painless, so people might ignore it, but the bacteria are disseminating to cause secondary and tertiary syphilis later.
Moving to section 6, skin, soft tissue, and bone.
For skin, it's mostly a battle between Staph aureus and Strepiogenes, impetigo, cellulitis, boils. Staph tends to be more localized and purulent, meaning pus-forming. Strep spreads more like cellulitis.
And if you hear crepitus.
Crepitus is that crackling sensation under the skin like bubble wrap. That means gas. That means gas gangrene. Clostridium perfringens, that is a surgical emergency.
Let's talk about bone. Osteomyelitis, infection of the bone.
Staph aureus is the #1 cause overall. But in, host factors allow us to be detectives. If it's a kid, it's usually hematogenous spread to the long bones. If it's a diabetic, it's contiguous spread from a foot ulcer.
And the specific associations.
If you see a patient with sickle cell disease and osteomyelitis, you have to think salmonella. There is a functional problem with their spleen and immune clearance that predisposes them to salmonella bone infections. And if you step on a rusty nail wearing sneakers...
Pseudomonas.
Right. Pseudomonas lives in the damp foam rubber of old sneakers. A puncture wound through the sole drives the bug into the bone.
Section 7. Systemic and opportunistic infections. Let's talk sepsis.
Sepsis is the body's overwhelming response to infection. When we draw blood cultures, we have to distinguish contamination from true infection.
Because skin has bacteria on it.
Exactly. If you grow coagulus-negative staph, like Staph epidermidis, in just 1 bottle out of 4, it's likely a skin contaminant from the needle stick. But if you grow Staph aureus or a gram-negative rod, like E. coli, that is almost always real. You never ignore Staph aureus in the blood.
And finally, the immunocompromised host. Specifically HIV and AIDS. You often refer to the CD4 count as a clock.
It is a countdown clock of risk. As the CD4 T cells, the generals of the immune system drop, different doors open for different pathogens. At any count, you can get TB or shingles. But when you drop below 200, the door opens for pneumocystis jirovecii. PCP pneumonia, that's the classic AIDS-defining illness.
And below 100.
You worry about toxoplasma in the brain and cryptococcus causing meningitis.
And below 50.
The really deep opportunists, Mycobacterium avium complex, or MTC. These are environmental bugs that a healthy person fights off without thinking, but they can be lethal when the immune system is essentially gone.
This has been a massive tour of the body. But now it's time to test if we've been listening. Expert, are you ready for the rapid recall?
I am ready. Fire away.
Let me give you a scenario. You tell me the bug and the why. For our listeners, try to answer before the expert does. Scenario 1. A newborn baby, 2 weeks old, fever, irritability, bulging fontanelle, spinal tap shows a gram-positive rod.
That is Listeria monocytogenes. Why? It's a neonatal meningitis, a birth canal bug, but the key is gram-positive rod. Strep B is a coccus, E. coli is gram-negative, Listeria is the rod.
Spot on. If you missed that, review Murray Chapter 78 on CNS infections. Scenario 2. 22-year-old male. Bloody diarrhea after eating BBQ chicken. A week later, he starts getting weakness in his legs that is moving up his body.
Campylobacter jejuni, why? Poultry source, bloody diarrhea, and the ascending paralysis is Guillain-Barré syndrome, a classic post-Campylobacter autoimmune reaction.
Perfect. Review the GI section of Chapter 78 for that one. Scenario 3. IV drug user. High fever. A new heart murmur is heard. Echocardiogram shows a vegetation on the right side of the heart.
Staphylococcus aureus, why? IV drug use targets the tricuspid valve on the right side. S. aureus is the most common and virulent skin pathogen introduced by the needle.
Review the cardiovascular section for endocarditis. Scenario 4. A family picnic. Everyone eats potato salad. 4 hours later, everyone is vomiting simultaneously.
Staphylococcus aureus again? Why? The incubation is too short for infection. 4 hours is preformed enterotoxin. Potato salad is the classic vehicle.
GI section again for toxin-mediated food poisoning. Scenario 5. A 10-year-old with sickle cell disease presenting with severe bone pain and fever.
Salmonella species. Why? While S. aureus is #1 overall, the high-yield association for sickle cell osteomyelitis is Salmonella.
Review bone and joint infections in Chapter 78. Final one, Scenario 6. An alcoholic patient coughs up thick, red, jelly-like sputum.
Klebsiella pneumonia. Why? The current jelly sputum is the hallmark. Alcoholism predisposes to aspiration, and Klebsiella loves that environment.
Check the respiratory section if you missed that. You nailed them all.
Those are the classic patterns. If you know those, you are thinking like a clinician.
So we've synthesized the journey. We've gone from head to toe.
We have. And the takeaway is that medicine is pattern recognition. You take the host, the geography, the timeline, and the specific symptom, and the list of potential bugs drops from thousands to maybe 3.
Before we sign off, I want to leave you, the listener, with a provocative thought.
Yeah.
We talked a lot about cultures growing bugs on plates, but the world is changing.
It is changing rapidly. We are moving from growing bugs to hunting DNA. We now have PCR panels where you take a drop of blood or sputum, and the machine looks for the DNA of 20 different organisms at once. It's faster, it's more sensitive. But does it make us lazy thinkers? If you just order the everything panel, do you lose the art of the differential diagnosis? And what happens when the machine says detected for an organism that is just a bystander, not the cause? The clinician still has to be the detective, and the machine gives you data. Only the human mind can turn that into a diagnosis.
A fascinating tension to consider as you move forward in your training. Will rapid DNA testing replace clinical intuition? Or will it demand even sharper critical thinking to interpret? For those who want the full charts and flow diagrams, and they really are beautiful, go check out Murray Chapter 78. It puts it all together visually.
It's the roadmap you need.
Thanks for diving deep with us. Keep those mental models sharp.
See you next time.